In simple words, sir, pharmacokinetic is something which body does to the drug, and it is like regarding the absorption, then distribution, metabolism, and elimination of the drug.
All right. Okay. So it is actually the absorption, distribution, metabolism, and elimination. Okay.
Yes,
and can you tell me something about what is bioavailability?
Bioavailability is a drug which is available in the plasma after injecting, sir, concentration of a drug, and when we give it in through IV, it is considered as 100% bioavailability, and then accordingly other routes of drug administration are compared with the IV injection, which is equivalent to 1.
Okay. What other routes can you tell me about?
So there are various routes apart from IV administration. There is a subcutaneous, then intramuscular, then there is a transdermal route, inhalational route, epidural route, intrathecal route, perrectal route, transnasal, means mucosal route through which the drug can be injected into the bodies. Then the interventional things are there in that case, then direct interventricular route. If catheter or intrathecal catheter is kept, through that also drugs can be given. So.
Okay. And what are the factors which affect the bioavailability?
So factors which affects the bioavailability, obviously the patient factors and drug factors. So patient factors like it's a route rather than patient, it's a route of administration, and the drug factors are physiochemical properties of the drugs, which is its protein binding, its lipid solubility of the drug, which will decide the bioavailability, sir.
Okay. Anything else you want to add?
This volume of distribution as well, sir.
Okay. And how do you measure this bioavailability? Can you?
So
can you illustrate the measurement of bioavailability? Can you show the difference between, for example, an IV route and an oral route? And how do you measure actually the?
Yes, sir. So on this is I'm just drawing on an x-axis and a y-axis. So plasma concentration on my y-axis and x-axis is the time. And obviously when we, it's 100% on the top of y-axis plasma concentration. And when we are giving IV, the graph goes like this. And for oral, so my this lower, this is the oral one. And this is a IV, starts from 100% bioavailability. And accordingly, we can calculate it by oral, the area under the curve of oral divided by area under the curve with the plasma, which will give us the bioavailability of oral or whatever route we can plot with, like so.
Okay. And may I ask you, what is first pass metabolism?
First pass metabolism. Metabolism of a drug which is proportion constant, in the sense the amount of drug which is it's related with the amount of drug which is present in the blood. Sorry, first you are asking me first pass.
Yes, I think you confused it with the
first order. I confused with the first order metabolism. First pass metabolism is when the first time the drug passes through the liver, the amount of drug which gets metabolized.
Just from, in the liver or anywhere else?
Or anywhere, like even in the guts or mucosa or wherever it gets before entering into the plasma. So that is the first pass effect.
Okay. And can you name some enzyme inducers or enzyme inhibitors?
For which affects the first pass, like when we talk about hepatic, there are cytochrome P450 pathway.
What are the drugs which induce? And what are the enzymes?
The inducers are carbamazepine, phenytoin, and then cimetidine, then alcohol, acute alcohol. These are the things which can induce the enzymes of cytochrome P450, and inhibitors are like ketoconazole, clarithromycin, antibiotic, metronidazole, then ranitidine, then even a grape juice, who are habitual to take it there also. In that patient also we can see the induction of cytochrome P450. Sir.
What is a hepatic extraction ratio, and what are the factors?
So a hepatic extraction ratio is extraction by the liver when the drug passes through the liver. Every time it passes through the liver, and obviously the factors affecting it is liver condition of the liver, then blood supply to the liver, functioning of the liver.
Okay. And can you tell me a drug which can be administered transdermally?
Transdermally, the drug like fentanyl, which we administer transdermally, sir, in a patch fashion. Then buprenorphine we administer transdermally. Then local anesthetic like lignocaine and prilocaine combination, what we call EMLA, that is administered transdermally.
And what are the factors which affects in a transdermal absorption of a drug?
In a transdermal absorption, obviously the area which is covered, the blood supply to the skin, then lipid solubility of the molecule which come into the picture regarding the transdermal absorption. Any other like temperature of the local skin, like if it is low, causing the vasoconstriction, it will decrease the plasma, it will decrease the transdermal absorption.
Okay. Can you tell me what determines the distribution of a drug in the body?
Distribution of a drug in the body is decided by its lipid solubility mainly, and protein binding, sir. And volume of distribution, which decides the.
Okay.
Yes.
And have you heard of the compartment model?
Yes, sir. Compartment model gives us the idea about the distribution of the drug. The compartment is there are usually 3 compartments in the body mainly. First compartment is what we call intravascular compartment, and then second compartment is high blood supply tissues and organs, and then the third compartment is low blood supply tissues like fat. And the drug gets distributed in these 3 compartments depending upon the bioavailability and the lipid solubility. And when we inject the drug, it is obviously the drug goes in first compartment, C1 compartment, intravascular compartment, and as we keep on giving the drug, it gets slowly distributed to the organs with a compartment 2 with a good blood supply, and then organ with a low blood supply where it gets stored. And the elimination happens in the same order because injection and elimination takes place in first compartment, and drug has to come back to the first compartment from the fat and from the organs into the blood before it gets eliminated. So.
Okay. Can you illustrate that for me? Is it possible?
Yes, sir. So here, this is the compartment, this is injection, this is the compartment 1, and compartment 2, compartment 3, and then elimination from the compartment 1. So compartment 1 to compartment 2, it is depend on the constant of solubility, like from while going to the compartment 1, reverse will happen in the same, and same principle applies to the compartment 3. And then once the drug is in a compartment 1, again it will get eliminated by compartment 3, so compartment 1.
Okay. And how do you then calculate a loading dose of a drug?
Sir, loading drug of a dose is calculated on a basis of what is the required plasma concentration and then volume of distribution of that drug. So depending on that, we can calculate the loading dose required for that particular drug.
And the rate of infusion for that same drug you want to keep?
Rate of infusion will be proportional to the rate of elimination, sir. Because and then rate of elimination depends on the volume of distribution and clearance, sir. So rate of infusion will be like proportional to the volume of distribution and clearance of that particular drug. So once we know that, we can calculate the rate of infusions of that particular drug.
Can you tell me what is context sensitive half time?
So context sensitive half-life of a particular drug is the half-life taken by a particular drug when given in an infusion form to get the eliminated. So more the duration of the infusion, it will take longer to get eliminated. Half-life will be longer when the drug is a context sensitive. And if the context insensitive, then in that case, the elimination half-life is not related with the duration of the infusion, sir.
Do you know the context sensitive half-life for propofol?
Context sensitive half-life for propofol, exactly figures I don't remember, sir, now, but it is 2 to 4 hours in between, which is a little higher than remifentanil, which is not sensitive, which is 2 to 3 minutes, and less than other drugs like fentanyl and thiopental and also.
And what is a time constant, and how is it different to half-life of a drug?
Sir, half-life is time taken by a drug, 50% of the proportion of the drug to eliminate from the available concentration at that particular time. And time constant, it is a time taken for 36.3% of the drug to get eliminated. So when we talk about a half-life, for a drug to get eliminated, at least for 96%, it will take 5 half-life, whereas 3 time constant to get eliminated. So that is the difference between half-life and time constants.
Okay. I'll just move into the next topic because I think a little too much the topic was and the time we have is little low. I just wanted to cover everything. So yes. I'm just going into the next one. So that is local anesthetics. So we'll just continue with this only. Okay. Yes, okay. So can you tell me about what are the local anesthetics which I know, and how do you classify them? And can you give me some examples from each field?
Yes, sir. Local anesthetics are the drugs which we use to create anesthesia locally or at the part of the body, and they are mainly chemically consist of the aromatic group, aromatic ring, and amine group. So this aromatic and then the difference is how they are connected with the bond makes the amine group. I'll just draw the group, sir.
Okay.
So we have a amine group, we have an aromatic ring, and they are how they are connected with each other. That bond decides which type of local anesthetic it is. And mainly we have a ester and we have a amide group. This is the aromatic ring, sir, and this is the amine group, and they are connected by this is my ester bond with the O, and NH it has got a amine bond, and depending on how they connected, there are esters are like cocaine, procaine, and etidocaine. Then amine, we have a lignocaine, bupivacaine, levobupivacaine, we have procaine, ropivacaine in our amine group, sir.
Okay. And what are the difference between the ester and the amide groups?
Sir, esters are as we had chemically seen, the esters are bounded by the ester group, and they are relatively unstable in a solution. Then they are metabolized by plasma esterase, and they create a PABA metabolite, which has got a high rate of creating a hypersensitivity. And whereas amine groups are relatively stable in a solution, this thing, and they are with or without preservative as well. Mostly they get metabolized in the liver, and depending on whether they have a preservative or not, there is a chances of reaction, sir.
Can you give me the okay? Do you know the significance of so how does a local anesthetic work exactly? Can you tell me the basic what is your understanding about the how it works in the
Yes, local anesthetics, they are basically, sir, membrane stabilizer, sodium channel blocker. They get basically they are weak base, and that's why they are depending upon their pKa constant, they are in either ionized or non-ionized state. Mostly they are in a ionized state. So when we inject the local anesthetics, the non-ionized fraction of the local anesthetic, it enters into the cell membrane, neuronal cell membrane, and inside the neuronal cell membrane, being the pH low, it gets converted into ionized, and then this local anesthetic, it gets attached from inside to the sodium channel, sir. When sodium channel is open, inactive state, and then it blocks the further activity of the channel, and that's how it blocks the action potential generation and the activation of the neuronal membrane. That's how the local anesthetic they make their actions, sir.
Okay. And do you know about the pKa and how it is related with the action of the local anesthetics?
Yes, sir. pKa is nothing but it's a constant, it's a pH at which the anesthetic solution is in equilibrium, that is 50% ionized, 60% non-ionized. And pKa matters because it is a non-ionized state which gets absorbed into the cell, and ionized state cannot get absorbed into the cell. So depending on the percentage of non-ionized state, it's decided whether the drug will get absorbed faster or not. And when we talk about lignocaine and bupivacaine, so lignocaine has got a 7.8 pKa, and bupivacaine has got 8.1. So considering this in a normal physiological pH of 7.4, almost 25% of the lignocaine is non-ionized state, and 15% is ionized state. And that's why lignocaine shows us the faster action or onset of action as compared to bupivacaine, sir. And that's how pKa plays the role in action of local anesthetics.
Can you tell me something about ropivacaine? What is ropivacaine?
Ropivacaine is a local anesthetic, sir. It is a isomer which has got a less affinity for cardiac sodium channels, and it is safer as compared to bupivacaine.
Let me put it this way. Can you compare bupivacaine and ropivacaine, please?
Yes, sir. So comparison of bupivacaine and ropivacaine, as I said, ropivacaine is safer as compared to bupivacaine from a toxicity point of view. So they have got a less motor blockade as compared to bupivacaine. Their duration of action is relatively same, or ropivacaine has got a little longer action. It can be given better in infusion form for a prolonged period in for analgesia as compared to bupivacaine.
Can you any other property which is anything else you want to add?
May I, sir?
Yes.
Yeah.
Bupivacaine is the racemic mixture of R and S enantiomer, and ropivacaine is the pure S enantiomer form, and it is has lower action. And as when we compare the lipid solubility, ropivacaine is little bit less lipid soluble as compared to the bupivacaine. So it penetrates less these large motor fibers, myelinated fibers. So it has discriminative analgesia, means it has more of sensory effect and less of motor effect. So and it is more cardiostable as compared to the bupivacaine.
Okay. Okay. So since you said about the cardiostable part, can you tell me about local anesthetic systemic toxicity?
So local anesthetic systemic toxicity is related with the blood level, plasma level of the local. Above 4 microgram per dl, the toxicity starts. Usually it starts with the perioral numbness, tingling sensation. And then as the plasma concentration increases, then you will get a central nervous system effects, which is disorientation, confusion, and can lead to convulsion as well. And as the levels go high above the 8 to 10 microgram per dl, it can affect on the heart as well, causing the arrhythmias and cardiac arrest.
And what is the treatment?
The treatment for local anesthetic toxicity is, if you are injecting, we need to stop immediately. Assess the patients. I'll go for a management from the ABC point of view. I'll see the airway, breathing and circulation stabilization, and depending on that, I will help the patient from ABC point of view, and I will give lipid emulsion along with lipid emulsion to chelate the drug or to bring the drug level from the plasma.
How do you give the lipid emulsion? What concentration?
Lipid emulsion, it's a 20% lipid emulsion we get with the dose of 50 ml per kg. I'll be giving that, and over a period of 2 to 3 minutes, and then
50 ml per kg.
50 ml per kg, yes, sir. 15.
And
I'll keep supportive treatment ongoing, and if required, I'll give the repeat dose of emulsions.
And how do you repeat it? Okay.
I don't remember.
And no problem at all. I'm just touching the points where
yes,
going through. That's all. And so one more thing I wanted to ask. So other than in regional anesthesia, where else do we use local anesthetics?
So local anesthetics,
do you know
1B as per the Wong-Williams classification, they are 1B antiarrhythmic, specifically lignocaine. So it is used for ventricular arrhythmias and as well as in the resuscitation, CPR as well as ACLS resuscitation of the cardiac arrest. And then we also use it to decrease the pressure response of laryngeal intubation to stabilize. And nowadays, even in a combination, we are using it for as an analgesic to support the analgesic in IV form in the dose of 3 milligram per kg given over a period of half an hour. Sir.
Why don't we use bupivacaine for arrhythmias instead of lignocaine?
Sir, bupivacaine itself is a cardiotoxic and it blocks the sodium channel irreversibly. whereas lignocaine has got a more membrane stabilizing effect. It acts on a open inactive sodium channel, giving the membrane stabilization.
Do you know anything about the additives we add in local anesthetics?
Local anesthetics are additive. We add mainly to reduce the absorption from the injection site, and that is adrenaline is added in the local anesthetic. Then even for increasing the or faster action or increasing the speed of action, we add soda bicarb in the local anesthetic so that more non-ionized form of the drug gets at the site of injection and faster action can be generated. So.
Okay. And what happens when we inject local anesthetic into an area which is infected, or if there is an abscess?
Yeah, so obviously, sir, as the area of injection or site of injection is having a abscess or infection, that means that area pH is more acidic, and in the more acidic pH, the local anesthetic being weak base, they get into more non-ionized state, and being in non-ionized state, they cannot penetrate the neuronal tissues and cannot exert the actions.
Okay. Last, I just wanted to know, can you tell me something about the pharmacokinetics of the drugs in the spinal and the epidural space?
Pharmacokinetics of the drug when we deposit the local
absorption, distribution, and elimination in the epidural and the spinal space.
Yeah,
I mean, in the subarachnoid space.
So when we deposit the local anesthetic into subarachnoid space, the distribution is on the dura depending on the CSF scene, and in epidural space, since it is a negative space, so distribution is less, covering less area and less speed. Then even the duration of action is less of a local anesthetic when deposited in the CSF as compared to epidural. Then denseness of a motor blockade is obviously going to be more when we deposit the local anesthetic in the intrathecal as compared to epidural.
Okay. Shall I go to the last part of my first session? That is the electrical safety.
Yes.
Okay.
Yes, sir.
Okay. So, sir, can you tell me what is an electric charge?
Sir, electric charge, it is a charge. It can be a positive charge or a negative charge. When the electron can be given out, it is negatively charged or positively charged. When it is accept, then the charge is measured in a coulomb. It is a current. When current is flowing, actually the charge is flowing, and when a charge passes to the point at a particular point in a particular time, we call it a current flowing, and we measure it in an ampere. When we say that 1 coulomb of a charge crosses the particular point in we call it a 1 ampere. It is a 6.24 into 10 to the power 18 coulombs when they cross. That is a 1 ampere of, when we say that 1 ampere of current is passed.
Okay.
They opposite, they attract each other. Equal charges, they repel each other.
Okay. Can you tell me Ohm's law?
Ohm's law is about the resistance afforded by a particular object for the flow of the charges, the flow of the current, and it is it depends upon the conducting ability of that particular substances. So if they are good conductor of charge electricity, we call them a conductor, and if they are not allowing, we call them a they are having more resistance to, like for example, conductors are metals, aluminiums, and non-conductors are wood, plastic, those rubber, that kind of things.
what is the potential difference? What do you mean by
potential difference is the difference at the two end of the substances where current is flowing. We call it the voltage, sir. And
resistance.
Resistance is a resistance offered by that substances to flow of the current. So we have a formula V is equal to IR. So it is a voltage is equal to amount current passing into the resistance. Sir.
Can you see the screen, sir?
Yes, sir.
And can you tell me about this diagram? What is it?
Diagram I am not able to see, sir.
Okay. Can you see my PowerPoint?
No, sir. No? You'll have to share the screen.
Yeah. Okay, I'll just get that and I will show you. Okay. Can you tell me about what is capacitance and what is inductance?
Capacitance is the ability of the ability to store the charge. It is measured in the farad. It is seen in the capacitors. And inductors is the coil of a wire which creates the electromagnetic forces and resists the current to flow, sir.
Okay. And what is impedance?
Impedance is again the resistance offered by the capacitor to store the currents.
And can you tell me some causes of the electrical interferences?
The causes of electrical interference in the operation theater, the most important cause is of cautery, sir. The use of cautery gives the electrical interference. It is a high frequency AC current which is delivering to the patient at the site of cauterization. Then there is a static electricity which gets forms, or there is a capacitor like action which forms between the lights above the patient and the table below the patient himself, which can again cause the electrical disturbance. That's all I can think of.
Okay. What are the main types of, can you tell me, can you tell me the different types of, how do you classify the medical electrical equipments? Like,
so medical electrical equipments are basically classified as per the protection they offer. Class 1, Class 2, and Class 3 is the classification we give. Class 1 is the earth equipment. Class 2 is a double insulated equipment. Then Class 3 is a low voltage equipment which carries the DC and very low voltage current. And then their further safety is generated by classifying further than how much current leakage they allow, sir. Depending on that, BF classification is done, in which B allows the 500 to 1 milliampere and 10 to 100 milliampere, and less than 1 milliampere is a C, sir. And there I can just draw their.
Yes. Thank you.
So this is the Class 1. This is double insulated Class 2. They are earth 1, and this Class 3, they are the one which allows the which works on a very low voltage, creating a less chances of patient to get the electric shock.
What are the anti-static measures we use in the theater?
Anti-static measures we use in the theater is we ourselves we see to that whatever equipments are there, they are earthed properly. Then they allow the passage of static current like wheels of the Boyle's machine or table, or we ourselves who are touching the patient wear the rubber slippers so that static current doesn't get accumulated and it gets earthed all the time, keeping the patient safe or preventing the patient from getting electric shocks.
Yeah. Thank you very much. I think it's almost, we crossed 37 minutes now, but it's okay. I mean, usually in the exam, it takes only 25 minutes, 12.5 and 12, but this is a practice. So I think even if we go beyond the time, it doesn't matter, because it's just that we need to know, you have to at least cover few points. And that's why I kept some few more topics, because I just wanted to cover. And this is how basically it is, because you will be speaking about a topic, and then in 5 minutes you will go around speaking about some other unrelated, totally unrelated topic. So just wanted to bring that contrast in. Anyway, thank you very much, sir. It was
Thank you. My honor.
Anyway, I'm trying to share my screen. I have the PowerPoints. Do you want me to share it right now, or finish my second session off and then I will do the sharing together? So that I can finish off the second session as well.
Yes, sir. After
I have made
second
some
session also we can do
PowerPoints from the information I have gathered, but of course, even you people also will have. So I have made a small PowerPoint for all the topics which I am doing.
We want you to share, sir. Definitely, we can do it after the second session.
All right. Okay. So who will be doing the second session?
Hello.
Good evening. Hello.
Good evening, sir.
Good evening.
My video is
Okay. I'm trying to share the because I need the screen to be shared. Is there any? I'm trying to. We have to click on the share button, right? The share screen below.
Yes, sir. Yes, sir. Yes,
But
sir.
it's and the desktop and share, but nothing is. It shows that allows Zoom to share your screen. Open system
Yes, sir.
preference security. So that. Okay. Anyway. Just give me a second. I'm just trying to get the. I don't know, something wrong with the, it's just showing open system preferences. I'm not able to. Okay. So I will just start with the first one. Meanwhile, I'll just try and get the thing work. Okay. So this is a case which I'm going to give you. You are called to the ward to see a patient with 45-year-old lady, 4 days post total abdominal hysterectomy under combined spinal and general anesthesia, developed respiratory distress, tachypnea, and hypotension. The immediate post-operative period was uneventful. That is what the gynecology resident has given you the information over the phone. There is no significant past medical history and no associated comorbidity. So you are called in to the ward to see the patient. Can you give me step-by-step? So what are you going to do the next?
Okay, so this is a 45-year-old lady. If I'm just repeating the history, sir, with the POD4 with total abdominal hysterectomy done under spinal and general anesthesia combined. She is now having tachypnea and hypotension.
Yes.
So first, I would like to assess off with the calming down the patient that everything is going to be fine. First thing. Secondly, get my team into action. Keep the system activated and connect all the monitors. Check for the vitals. Assess her airway, breathing, and circulation. Meanwhile, the system and all gets into picture, like ECG. I would connect a 5-lead ECG, a monitor which will be connected to the patient, check her saturations, and also blood pressure to be recorded manually or by the system, sir. Now, since she's already having tachypnea, I would like to know the saturation. If she's having any respiratory distress, or is she able to complete her sentence, or she's finding it very difficult to breathe when she's lying down, or any association or positional respiratory distress is it? And coming to the hypotension, I would already, since she's already in the hospital on a POD4, I would presume that she already has an IV line, and I would start off with an IV drip, normal isotonic saline at least 100 ml per hour. The fluid will be started, sir. Then coming to assessing her airway, if she's able to maintain her airway, she's able to talk, conscious and oriented, then I would like to put an oxygen mask for her initially in the ward. Okay, till my system, everything comes into picture, the team is activated. And then coming to the breathing, if she is not able to maintain her airway, then I would like to give a jaw thrust, get an ambo bag and assist her ventilation. If that is not possible, then we have JR circuit, the vein circuits which are available in the ward. I would like to assess her respiration by holding the mask for a few minutes, just giving her a comforting position and giving a jaw thrust and head lift. And the hypotension, I would like to keep checking the blood pressure every 3 to 4 minutes. If there is any improvement with the fluid, and give her a slightly head low or a Trendelenburg position so that it will help her. I would like the gynecology resident to have a look at her abdomen for any bleeding, or vaginally if there is any bleeding. And I would like to ask if there is any repeat hemoglobin was done post surgery, or how much of the blood loss was there, how much fluid she has received over 2 to 3 days, how much was her urine output, just to know her circulatory status, sir.
Okay, so immediately now, what do you want to know further? That's my next thing, my next question.
Sir, intraoperative events like if she had
So
major blood
immediately
loss.
after you assess the patient, that she can, you said that you assess the patient, you will check whether her ABCs, you will check whether she is able to speak sentences. Now, immediately, what do you want to know? The next.
I'm sorry.
I mean,
sir,
what will be the next things? Like, you want to know what will be a next step? Like, no, I'm just trying to bring in more, just to streamline it. You have told me
yes, sir,
multiple things. Just wanted to streamline it. Nothing.
Okay, sir.
So
Sir,
you saw
first is airway.
Yeah.
Airway, then is a breathing.
Okay.
Breathing pattern I would like to assess.
I can tell you the values if you want. The respiratory rate is around 40 per minute. Heart rate is around 140 per minute. The blood pressure is around 80/50. Saturation is 90% on 8 liters of oxygen by mass. So this is what you see when you reach there and assess the patient. Yeah. And temperature-wise, it's 95.6. That's what the staff who is caring her has told you. And on auscultation, you can hear bilateral chord crepitations. Assessing the peripheries, they are cold. Capillary refill time is only 4 seconds. On palpation of the abdomen, it looks it's distended. You cannot hear any bowel sounds. And you ask the staff, was there any urine output? Because she is not catheterized, and she said for the past 3 hours she has not passed urine. Okay.
Okay, so she has got coarse crepitations and she has got no urine output.
Okay.
The two important, and the abdomen is distended. So either suspecting a bladder injury during the surgery, but very unlikely because it has been POD4.
Okay.
And if it is only with the history of coarse crepitations and bleeding inside the abdomen, any of the ligature might have slipped inside during the anastomosis, then that can also cause, because of hypotension, there can be zero urine output. That is a further circulatory. It is one of the key signs to say that she needs to be cared in a high definition unit or shifted immediately to the intensive care unit. And I would like to, since she's already having tachypnea, I would like to put her on a high flow oxygen mask, the Venturi mask, which are available. And then I would like to put off the one more IV cannula, wide bore IV cannula, 16 gauge probably. And
do you want to know anything from her investigations?
Hemoglobin and
her hemoglobin is 10.2, white cell count is 4,000, platelet is 122,000, creatinine is 1.8, urea is 50, C reactive protein is 210, SGPT is 50, SGOT is 48, albumin is 29, INR is 1.3. And the gynecology resident had already asked for an ABG, and so somebody had taken the ABG, which showed a pH of 7.25, EaO2 of 60, EaCO2 of 33, bicarbonate of 13, and base excess of -8.
Bicarbonate, so PCO2, I didn't get.
PCO2 of 33. And bicarbonate of 13, and base excess of -8.
She is in metabolic acidosis. HP is okay.
So this picture this is the investigation I have given you. So what will you do next? The patient is in the ward. So what will be your next plan?
I would like to shift her to the intensive care unit. where I would be able to care her for a better place for caring such patients. And I would, as I said, I would like to start off with another wide bore cannula. I would ask for a fast scan, which would be done immediately in the intensive care, or a scan which will be done by the intensive. We only do the scans usually in the ICU to check for any
what kind of scan?
abdominal, sir. How do I say it?
It's okay.
We usually
no, take it easy. No problem. This is not an exam, so you can just calm down.
Sir,
and
usually we usually do the abdominal scan, check the bladder distension, and we check for the movements of the bowel. We also check for any perihepatic fluid collections, and we also check for pleural effusion or B lines, fluid lines inside the lung.
Okay, there was
these scans
B lines for this patient. There were B lines, but there was no perihepatic collection or anything. Additionally, if the IVC was looking collapsed, and there was some collection in the suprapubic area, but not it was a mild collection.
Okay, sir.
So what do you think you'll be suspecting in this patient? What kind of a problem is happening, and what will be you will be aiming at in treating her?
Sir, one is intra-abdominal sepsis, since CRP is very high. Second is pulmonary embolism, because a 45-year-old lady coming for a TAH case. And
so what will be the next best investigation which you can make to rule out all these things, and what are your next steps in the treatment plan when you shift her to the intensive care unit?
So in the intensive care unit, I think I will intubate her and put her on a controlled mechanical ventilation. First is to reduce her respiratory effort, what she is putting in, and also to some point of view to correct the hypotension that is already set in. I would like to secure a central line and an arterial line also. A central line so that I can assess her fluid status, as well as give inotropic support because she's already hypotensive, and large volume if required to transfuse blood if required. Third is arterial line to make a frequent ABGs, and also to get a correct value of the blood pressure at that point of time, if my treatment is working or not. I would like to first start off treating her with the head low position only, sir, and send the samples for I would like to catheterize her also. Then whatever is the urine coming, I would like to send it for the investigations, the cultures.
No, but there is no urine output.
Bladder is not.
Yeah, so for the past 3 hours there was no urine output, and they catheterized and nothing was coming out. Okay, so you said about intra-abdominal sepsis. So it's okay. So you said about intra-abdominal sepsis. What do you know about? So can you just tell me what is sepsis? What?
Sir, bacteremia in the. It is a systemic bacteremia, can be termed as sepsis. I don't know the exact definition, sir.
Okay, can you tell me the different stages? Like systemic inflammatory response syndrome, sepsis, severe sepsis. How do you classify it like?
No, sir. I'm zero with this ICU. I'm trying to cope it up.
Is there okay? Now, so how do you manage the patient? Like, what else can you do for this patient if you are suspecting a sepsis in this patient?
So first I would also get a, first is, as I've said, airway, breathing and circulation. I would get a CT abdomen done and also get a venous, lower limb venous Dopplers done.
Okay,
to rule out
CT
any
abdomen. So CT abdomen.
CT abdomen.
So CT. So once you will stabilize the patient by intubating and all, then you will send the patient for a CT abdomen. And do you want a CT chest as well to rule out pulmonary embolism, a CT pulmonary angio, or just a CT
so
abdomen?
First, let me.
You will get
Initially, I would like to.
Okay. So a CT abdomen revealed peritonitis, fecal peritonitis maybe, but peritonitis. So what will be your next step then?
So then I would call the surgeon on call. She has to be taken immediately to give a bubble, to give a thorough abdominal wash. That is one first thing, and start her on an empirical antibiotic treatment till she gets stabilized to be in the shifted to the operation theater. And
you said about
do the
putting a central line in. So while putting in a central line in, what will be the most important thing you will do in this patient? Will you send for any other further investigations?
Mixed venous
Culture.
Yeah. What is that?
So mixed venous saturation.
Yeah. Anything else?
Lactates.
Okay. And do you want to send for a blood culture?
Yes, sir. Sir, I would like to send the throat swab. When I intubate only, I would be sending the throat swab, the blood cultures. And as I was talking about, urine was not available. So we left the urine part there.
Okay. And anything else? Okay. So you send for the CT. The patient is brought back to the ITU. You inform the surgery team. And meanwhile, what will you be doing to the patient? So you're suspecting a sepsis, almost confirm, it is confirmed with the CT. So what will be the next step you will be doing before the patient goes into the theater?
So start off with the empirical antibiotic treatment.
Let me put the question in this way. What do you mean by early goal-directed therapy? Have you heard of it in sepsis? Okay. So there is this surviving sepsis guideline 2021, which has given some valid points apart from the sepsis topics which you can read. So which actually guide us to the treatment in patients with sepsis. Is there anyone? Can I? If I'm sorry, if can I ask participants if they want to add something?
Please.
Is there anyone who wants to add in within this case just to help our doctor here?
Sir, may I?
Yes, please. So can you just start from the beginning if you want? So you saw this patient in the ward.
Yeah. So this is a patient I am seeing in the ward, which is hypotensive, tachycardic, having a surgery 4 days back. So she seems to be in sepsis, or the DD may go in the line of pulmonary embolism. So if we are suspecting a sepsis, we'll shift the patient to the ICU. We'll assess the patient according to the airway, breathing and circulation. So I'll intubate the patient, as we have said that the patient is already having low saturation on 8 liters of fluid. So I'll intubate the patient. I'll then put her on the controlled ventilation. Then I'll start with the assessing the circulation. I'll check the IV line. I'll access the one more line and start with the IV fluid at the rate of 30 ml per kg. Then I'll take out the blood cultures, and after taking the blood cultures, I'll start the empirical antibiotic. Then, as per the blood pressure, I'll put the patient on the vasopressor support. And
what kind of support do you prefer?
Noradrenaline is the first drug of choice to be started. So I'll put the patient on the noradrenaline if the patient is not responding to the fluids. Then I'll send.
What is the maximum dose of noradrenaline you will be giving?
So the maximum dose I'll be giving is 20 micrograms per minute.
Okay.
Then I'll I'll measure the lactates also
Okay.
to see the patient is having hypoperfusion or not. This will be my initial strategy. And after stabilizing the patient, I'll go for further investigation, which include the complete blood count, serum urea, creatinine with electrolytes, uh, ultrasound abdomen and the CT abdomen. Yeah, so these will be the investigation, and we'll move accordingly as per these investigations. Yeah, and of course, catheterize the patient as the patient is self-voiding. Catheterize the patient to look for input and output chart.
Okay, and the patient's output is almost nil. So after giving the fluids as how you said, 30 ml per kg, the initial fluid resuscitation, we started getting very, very low amounts of urine. But still it is only just 10 or 20 mils per hour. So what will be your next next step?
So with the vasopressor support and the IV fluid support, when the blood pressure got stabilized, I'll give the patient a furosemide challenge. And if the patient responds to the furosemide challenge, it's good. If the patient will not respond to the furosemide challenge, I'll I'll ask the patient to put on the resuscitation therapy.
I didn't hear that.
Okay. So if the patient will not respond to the furosemide challenge first,
Okay.
and on the basis of the investigations like urea, creatinine, and the potassium level, I'll go for the continuous renal replacement therapy.
Okay, and potassium level was around 6.5.
So before going for the renal replacement therapy, I'll start the anti-hyperkalemic measure. So I'll put the patient, I'll give the patient 10 ml of 10% calcium gluconate, which will help the patient stabilize the myocardium. Then I'll give the patient 10 units of insulin in 50 ml of 50% dextrose in 10 to 20 minutes, which will drive the potassium back into the cells. I'll give the patient, nebulize the patient with 5 mg of beta 1 agonist, salbutamol, which will again help the drive potassium inside. Sodium bicarbonate as the patient is acidotic. So this will be my
as our Dr. Kritika had rightly said about the CT abdomen. So this patient was taken for a CT abdomen before being shifted to the intensive care unit to find out the reason for the abdominal distensions. And there was as I said, they had found out some peritonitis over there, and the discussion was happening with the surgical team. So meanwhile, you were doing the initial resuscitation. So since you said that the patient is in acute kidney injury and you did the immediate necessary treatment for hyperkalemia, and what will be a next step? So now we have to optimize the patient and then so what will be your next step? Like before starting a renal replacement therapy, will you take discuss with the surgical team what will be there to know what is their next plan, or so what will from there, how will you go?
So now after the initial stabilization, and the patient is now to be taken up for the surgery, the patient is expected. So we will discuss it will be a team approach. We will discuss it with the surgical team and we'll proceed accordingly. So I'll check before proceeding for the surgery, I'll check the vitals. The patient is having a normal, near normal blood pressure. The pulse rate has been settled. Whatever urine output, if there is any, and the lactates have reduced to the normal level. ABG has come to a normal pH level. So after ensuring all these things, we'll go for surgery. We'll proceed with the surgery.
Okay. And what about antibiotics? what kind of antibiotics will you start, and in what time? What is a...
So that we have already started before, after just taking the samples of blood culture, we have started the empirical antibiotic, and we'll start the, once the blood culture reports will come, we'll start the antibiotic accordingly, which will be acting against the organism.
Okay, so this patient was taken into the theater, and so they apparently did a laparotomy. They had to wash out. There was a rent on the large intestine, and they closed it. They brought the patient back now from the theater to the intensive care unit. So what will be the next plan of action for the patient? So can you just tell me what all how the sepsis can affect, or what is a multi-organ dysfunction, and what are the stages of sepsis? So I just want to go into...
So sepsis is basically the organ dysfunction due to the dysregulated host response system. Previously, they have classified in systemic inflammatory response syndrome, then sepsis, then severe sepsis, and septic shock. Now they have removed all these terms, and they have just classified the sepsis in the septic shock. So sepsis is basically organ dysfunction due to dysregulated host response, and septic shock is sepsis plus the patient having shock, that is the mean arterial pressure less than 65 millimeters of mercury after giving fluids. The patient is not responding to fluid given. Then it's called septic shock.
Okay, and what is the current criteria for adding steroids?
So in sepsis, current sepsis, like Surviving Sepsis Guidelines 2021, they have recommended if role of steroids, they have mentioned that if the antibiotic has steroids have to be given, they have to be given early in the treatment. They have no role like later in the course. So they should be given early. So we can give hydrocortisone 20 to 100 milligrams IV.
Oh. Can you hear me?
Hello.
Yeah.
Your voice is echoing, sir.
One second. Okay, and regarding the so I was just asking about so coming to the renal function. So can you tell me what is the rifle criteria?
The rifle criteria denotes the staging of acute kidney injury. So R denotes the rifle in R is reduced. Hello. So R is risk, I is injury, F is failure, L is loss, and E is end-stage disease. So they use the criteria of urine output and the serum creatinine and the glomerular filtration rate to divide them into the rifle criteria. So in the risk, the GFR is less than 25%. Decrease in GFR is less than 25%, and the serum creatinine is more than 0.5 to 2 times of the previous value, and the urine output is less than 0.5 ml per kg per hour for 6 hours. In injury, the serum creatinine is 2 to 3 times of the baseline value, and the GFR is decreased more than 50% of the baseline value, and urine output is 0.5 ml per kg per hour for more than 12 hours. In failure, the creatinine is more than 3 times of the baseline value, with GFR, decrease in GFR more than 75%, and the urine output less than 0.3 ml per kg per hour for 24 hours. And the loss is persistent loss of renal function for more than 4 weeks. And in end stage, there is a persistent loss of renal function for more than 3 months.
Okay. And can you tell me about the method of supportive treatment for acute kidney injury in the intensive care? Or what is renal replacement therapy? What are your...
renal replacement therapy we can use if the patient is in AKI. So there are two types of therapies, intermittent and the continuous therapy. Intermittent therapy is intermittent hemodialysis and the peritoneal dialysis, and the continuous therapy has got hemofiltration, hemodialysis, hemodiafiltration, and the slow continuous ultrafiltration. In the continuous renal replacement therapy, the hemofiltration relies on the mechanism of convection, and the hemodialysis relies on the mechanism of diffusion. In diffusion, because of the concentration gradient, the solute particles are removed from the blood to the into ultrafiltrate, and in the convection, the solute particles are basically there is a high pressure on the blood side and the lower negative pressure on the dialysate side. So there is basically a solvent drag that the movement of the solvent will cause the small molecule to drag with them and help the remove the solute particles.
Okay, I think it has gone a little long today. Sorry, I just wanted to cover. I'm not able to share the screen. I can send the. It is there in my mobile. So I can share it in our WhatsApp group.
Yes, sir. Yes.
The PowerPoints which I have made. I just wanted to show one more thing. I don't know if it is visible for you. I don't know, something wrong with my computer. It's not letting me share my desktop. So just wanted to show if it is visible.
Yes, sir. The ECG is visible, sir.
Yeah.
So you want to comment on it?
Yes.
So this is an ECG strip showing 12-lead ECG with having a rate of there's reflection coming.
Sorry.
Your phone got screen got.
Yeah.
So if you can share this ECG on WhatsApp group.
Yeah, I can.
Yeah, that will be helpful to that.
And the X-ray as well.
Yeah, so this is a 12-lead ECG showing a rate of around 150, and the rhythm is irregular. Then the axis is the left axis deviation. There is a left axis deviation. The chest leads is showing pattern. So it's a right bundle branch block. B1. Actually, sorry, sir, I didn't read ECG, so I'm not able to.
Okay, I'll share one more ECG if you can just see.
Okay, I can. X-ray I read a bit, so I can go systematically in X-ray. So this is an X-ray of chest with so projection is PA view. It's showing the PA view. Then not rotated. It's not rotated. Then the image is overexposed, a little bit overexposed, because the lower vertebrae are also visible through it, and the penetration. And then the airway, regarding the airway, the trachea is seen to be a little pushed towards the left side.
Yes.
With the normal bronchi. Then regarding breathing, the right lung is compressed, and we can't see the bronchovascular markings in the right lung. Then the cardiovascular, as I said, the border of the heart, the right border of the heart is obscured. Then this is a X-ray showing right-sided pneumothorax.
Yes, very good. And it's an emergency, so it's an
tension pneumothorax.
Yeah.
Yeah.
And
the size is more than 2 centimeters. So
okay, so there was a discussion about how about the interpretation of ECG and X-ray. So I had made a PowerPoint about it, and I have shared it already in our group. It is.
So we didn't get the PowerPoint.
The ECG is atrial fibrillation with nodal rhythm and branch block.
Yes, and can you comment on the next ECG as well, please?
I'll just check it, sir.
Yes.
It's a heart block.
It's a type 1 block, sir, with an increasing PR interval and then P drop.
Yeah.
Or maybe something else?
Not type 1.
Yes.
It's not type 1. It's Wenckebach 2. It's Wenckebach 2. Type, like not Wenckebach, it's type 2, the second degree heart block, type 2.
Okay, so apparently it is a so there is no much relation between the P waves and the QRS. So
it's a complete heart
third
block.
degree heart block, sir. Complete heart block.
Yes. Yeah. And so one more X-ray.
So what's the first ECG?
Atrial fibrillation.
Yeah, it's atrial fibrillation. Irregular labor.
And so
in this case, the VIVA will go according to the management, isn't it, sir?
Usually they don't go, they just stop it where the diagnosis, and they go to the next topic. That's what they do, because they just want to assess. That was in my case, because I had got a similar ECG with atrial fibrillation, and my X-ray was a feeding tube into the lungs, nasogastric tube, which is going into the lungs. So I just about it with by interpreting in a in a pattern, and that's it. They went to the next question, because it is only 25 minutes and they're very strict about the time, so they don't sway much from the topic so much. Here even though we took time, we took almost 1.5 hours. I'm sorry about it. But
it's for our benefit, sir.
Yeah, but there, what they do is they're very strict about the time. So 2 examiners will be there, and they will be very strict about the time. And we have to, if we know the answer, we have to like confidently give, like really bombard that, so that they go into the next topic and finish off the set of questions. And if we don't know the answer at all, or if we just go, blank, sometimes it happens. Like we just go blank, immediately say, I'm not getting, or I'm not, I don't remember it right now. So they can go to the next question. Otherwise, what will happen is we will start telling, beating around the bush, and that will not fetch us any points. And we will be losing time on next topics, which probably we will know very well. I hope you understood all. So,
yes.
Yeah. So I am sorry. I actually made 4 PowerPoint presentations to give you people, but apparently I don't know, something wrong with my system. I'm not that good with the computers, and also I have to now.
So you can share it on the group, sir. You can share it on the group.
Yeah, so I will share that on the group, and I promise in the next presentation I will sort this out, and I will do a screen share.
It was an excellent class. So the last chest X-ray showing the hernia. Is it diaphragmatic hernia?
That is it is a hiatus hernia. So how
the posterior mediastinum mass is seen.
Yeah,
the shadow is seen in the posterior mediastinum behind the heart.
Yeah. So how you have to interpret, I have taken it from the certain FRCA sites and some books and all. So I have just consolidated it as much as possible, and that's how I made the presentation. So I have put that in the group. The other presentations also I try to share it in the group. So regarding the sepsis, I just wanted to say, because they will be what they will be looking about sepsis is they want to know exactly the stepwise measures you will be taking, because they just want to see whether we can safely manage a patient whom we see in the ward or in the accident and emergency, in the casualty. From there, how we manage that patient till the intensive care, and further what we do. So we have to learn it in a stepwise manner, like we had discussed here about how we, what are the initial things what we assess on the patient. So what are the immediate measures what we will do to save that patient? What are the immediate investigations we will do? What are the immediate treatment measures in first 1 hour, what we will do, next few hours, what we will do? What are the like the investigation, like a CT scan, if it is. So if both ultrasound and CT we need to take, then rather we go for a CT, and we get it much clearer picture rather than waiting for ultrasound and then going into CT. So those things we can do, starting the treatment like the antibiotic therapy, the early goal-directed therapy regarding the fluids, IV fluids, and about the vasopressors. So what are the first line of vasopressors we give, and when is it when we start the second line of vasopressors? Do we require a third line of vasopressors? What are the investigations other than the normal investigations maybe that other doctor might have done? What extra investigations do we need in this patient, which can guide us in the treatment of this patient? And how we discuss with the surgical team, because as we know that for peritonitis, the only way we can control that source of infection is to open, and they have to suture the rent which has happened in the intestine, and then they have to give a proper wash, that because that is the first thing we can do to control the ongoing infectious thing. So then we discussed about that patient is having tachypnea and her respiratory rate was very high. So that means and with cold crepitation, so we can do a chest X-ray or even a chest CT. When we are taking the patient for an abdomen CT, we can do a chest CT, and we will see if there is signs of ARDS, as rightly said by doctor regarding the intubation and ventilation. So what are the ventilation so we will have to make a diagnosis what kind of lung pathology has happened here. So mostly it will be a acute respiratory distress syndrome following the sepsis, as part of the sepsis. So in acute respiratory distress syndrome, what will be our ventilation strategies? What will be the optimal tidal volume we will be doing for this patient? So all these things, like in ARDS, the recent guidelines suggest about doing a prone ventilation, but in this patient we will not be able to do a prone ventilation because the patient is going in for a surgery, and so it will be difficult to do a prone ventilation. Then the next point we come is for the acute kidney injury. So what kind of support we can do, as we discussed here regarding the renal replacement therapy. So when should we start the renal replacement therapy? When there is metabolic acidosis, when there is hyperkalemia, when there is azotemia, increased urea and creatinine, and so these are the so there are strategies where when should we start the renal replacement therapy and how many days we will continue the renal replacement therapy. And in renal replacement therapy we use anticoagulants. So in this particular patient, what kind of anticoagulation should we use? And one another thing what we should remember in sepsis patients is it is strongly recommended giving a DVT prophylaxis, VTE prophylaxis, like a low molecular weight heparin. Now, what is the role of steroids? So there are recent studies also about the role of steroids, whether it is strongly recommended or weakly recommended. So I would suggest that we should all go through the surviving sepsis guidelines of 2021 and compare it with the 2016 guidelines. So we will get a lot of points where we can add, and we can. So what I would say is, when it comes to sepsis, when you are getting a patient of sepsis, rather than they go into the pathology, and they will be mostly asking regarding how you are going to manage the patient. So make the points in such a way that you have a clear idea of how to bring about the management of this patient. Yeah. Any points to add?
Got it, sir.
Sir, one small doubt, sir.
Yes, please.
Hello.
Yeah.
Sir, usually this is happening to me every time that I get stuck in between, and I am not able to go ahead. I'm not able to understand what the examiner wants from me. I get stuck with one question. Say, this is my second attempt, but in my first attempt also, they asked me lung pressure volume relations with the oxygenation and carbon dioxide. That was my first opening question. I spoke all about from ODC to the oxygen cascade, everything, but the convincing thing was not there. I was not able to convince them. Finally, I wanted to ask them, what do you want? This is everything I have told from starting from oxygenation to the end. I was not sure what exactly they wanted.
Even I had the same problem. Even I had the same problem with my wife. I had the same problem. So before going for the Viva, what I used to regularly do was, I found a study partner. I used to sit with him, and I used to loudly I used to say my answers out like. So I was literally practicing that out. Or even to what I will do is with my colleagues, or even I used to catch my poor anesthesia technicians. I used to give them classes, and they will go like they don't understand how it goes above their head. But I didn't care. I will over some tea and snacks, I used to discuss these things with them, because so that it was a practice session for me. So literally so I think the best thing is to practice and learn the illustrations, whatever diagrams. So I would suggest that book called Matthew Plunkett, the book. So in that there are a lot of illustration graphs and illustrations. So try to learn as much as illustrations possible, and they really appreciate if you can illustrate correctly. But remember one thing, when you are going for illustrations, it should be perfectly correct. You cannot make mistakes in that, because that will then cause you more damage than benefit. So that is one thing you can do. And second thing, as I said, is practice by saying it out, the answers, and being stuck. So there is actually, it can happen to anybody, but it just depends how you practice. That's all. So, and yeah, and the examiners, they are trained to be in a very, what do you call, you cannot make it out from their face, whether they are judging you or what they are thinking. So there is no use looking at them. So yeah.
No, they'll just
So basically, it is like I said, regarding a case history, if they are giving, it is all how you manage, how safe an anesthetist you are, how safe an intensivist you are, how you will bring about the treatment of this patient, how will you do it safely. So that's all they want to know. But with the supportive information from the recent guidelines and protocols. So you just need to be aware of it. And even X-ray and ECG, when you look at it, just interpret. So I just gave whatever I could gather from here and there. I have consolidated in it. It's not in a very good way because I didn't have much time also. So I had to do everything in. So I have tried to consolidate and put it in as a PowerPoint presentation. Okay, I think it's almost 1.5 hours. I'm sorry to keep you guys waiting. Anyway,
thank you very much, sir.
Thanks for taking out that much time for us.
Yeah.
Thank you, sir.
Next time I will try to share the screen properly. Yeah.
Okay, sir.
Thank you so much.
Thank you, sir. Good night.
Good night.
Thank you, sir.